Yeah. So evaluation of a patient with dry eye disease, I'm just going to cover the basic tests in this. So we know the normal tear film, it has mucin layer, aqueous layer, and lipid layer. Dry eye disease can be caused either by reduced tear production or increased evaporation. Depending on that, it is aqueous deficiency or evaporative disease. Then what is ocular surface? Ocular surface comprises of it is a interface between the functioning eye and environment, and it consists of palpebral and bulbar conjunctival epithelium, corneal epithelium, and tear film, and the adnexal structures. And this is what we need to test. So first would be taking the history in terms of what symptoms the patient is experiencing. Then quantifying these symptoms is what is done with the help of questionnaires. So there are different dry eye questionnaires like the Ocular Surface Disease Index or the SPEED questionnaire and the McMoney's questionnaire. I'm going to skip this. And then in the physical examination, you should look at what are the facial features. Are there any signs of rosacea or floppy lids? If there is any infrequent blinking, what is the size of the palpebral aperture? And if there are any malpositions of lids. Again, slit lamp examination would include how the lid margins are, whether there is any thickening, scarring, and keratinization, if there are any misdirected eyelashes, keratinization of conjunctiva and cornea, whether there's any vascularization or pannus on the cornea, and then tear film assessment for filaments and debris. And last but not the least, corneal sensations are important. Then tear film stability is usually checked with the help of fluorescein dye installation, where usually you should use a non-preserved fluorescein drop, and the time between the last blink and the appearance of first break is your TBUT. There is also something called as non-invasive TBUT, where a placebo image is projected on the tear film, and then you look at the tear breakup here. So if there is a breakup in the image, that is how it picks up the first TBUT. That is a non-invasive. Normal cutoff would be less than 10 seconds. Then vital dye staining, there is fluorescein, lysamine green, rose bengal. So in fluorescein staining, it usually is used for corneal staining more as compared to conjunctival, and it is 1 to 2% of sodium fluorescein which is used and observed under cobalt blue filter. And what it does is it permeates the intercellular junctions where the corneal epithelium is disrupted. So you can make out where the abrasions are and corneal epithelial defects. Then in lysamine green staining, it is more for the conjunctival staining. So it stains the dead and degenerated cells and stains conjunctiva better. When it comes to rose bengal dye, that stains the ocular surface which is devoid of any mucus or where there is devitalized cells. So that is where rose bengal dye staining is used. And tear film meniscometry is mainly to measure the slit lamp height and the average tear meniscus. Usually it is available in keratographs, but you can also do the fluorescein staining in order to measure the tear film height. Height of less than 0.2 millimeters would be abnormal. Then coming to Schirmer's, so Schirmer's test is mainly for your aqueous component of your tear film, whether the aqueous component is being produced or not. So there's a strip of filter paper which is placed in the lower conjunctival cul-de-sac, and then you look at the wetting over 5 minutes. So Schirmer's 1 measures your basal as well as reflex secretions. In Schirmer's 2, you irritate the nasal mucosa with a cotton-tipped applicator and measure the reflex secretion. And Schirmer's 3 is now obsolete, but it was when the subject was asked to stare at the sun. So tear Ferning test is to look at whether the mucoid component of the tear is normal or not. So in that, the mucus forms, if the mucus is normal, it will form these kind of ferns when it dries up. And if it is a dry eye, then there are no ferns which are seen. This is a classification called Rolando's classification, where the type 1 and type 2, where there are ferns seen, is normal. But if it is a dry eye subject, then there'll be broken up ferns or there'll be no ferning at all. And then impression cytology is used to look at whether there is any metaplasia of the cell. So nitrocellulose filter paper is used on the area of interest to get for the idea of taking off some superficial 2 to 3 layers of cells, and then it is stained to look at the conjunctival goblet cells. Then in mybography, there is a contact mybography which is not used these days, but infrared mybography is what is used. So in that, the ducts are hyperluminescent. This is how the normal glands would appear, and this is how gland dropouts would appear. So you don't have any hyperluminescence in this area where there is gland dropout. And then there is a scoring which is given, like score 0, there is no loss. Less than 1/3 loss would be score 1, 1/3 to 2/3 is score 2, and score 3 is more than 2/3. And lastly, like I mentioned, corneal sensations are important. They can be both cause as well as effect of dry eye. And I think myometry and tearfilm osmolarity is something that I can skip. So just to summarize, evaluation of unhealthy ocular surface would involve a careful examination of symptoms as well as signs. You can use dry eye questionnaires to objectively quantify the symptoms. Tearfilm analysis would be obviously important using vital dye stainings and fluorescein staining. Mybography to look at the meibomian glands. Impression cytology would give a picture about how the goblet cells and the conjunctival health is and whether there is any metaplasia and dysplasia. And then newer diagnostic techniques include the tearfilm osmolarity and myometry. Thank you very much.
Thank you, Dr. Rashmi, for a very eloquent idea about corneal topography as well as covering Dr. Soham's lecture. Thank you very much. If you do not have a mebography in your place, what will you do? Autoref, yes, that's good. You can just use the autorefractometer. You can just see. It's also something that works like an infrared mebography. Okay, so if you have not used that, please go back to your places, avert the lid, and try to do an autorefractometer on that. Not for refraction, but to check the meibomian glands. You will be really surprised.